Hello, everyone, and welcome back to CuriousCat. Today, we're going to be having a look at some more clinical skills, specifically now at your urinary system review. So, as with any systems review, we're going to start off with pain and take a very good pain history. When it comes to the urinary system, though, common presentations that you'll be come to learn about is with the kidneys in particular, you would probably associate that more with flank pain, so pain up over here around your back and on the sides. And then if you hear about the loin to groin pain, it's a very big buzzwordy thing, especially if it's colicky as well. That indicates you've got some sort of an obstruction in the ureters. And that's why you get the colicky pain, because that obstruction of the lumen, as it's trying to peristaltically move around it, causes that intermittent pain that comes in waves. You can also have dysuria, which is pain on urination, and that can again be linked to a lot of things like UTIs or STIs, but you'll come to again learn about how you can further narrow that down with the other questions here. So as with any pain history, you want to go through WWQQ, AA BICE, and take a very good history of that pain. You might want to start off more general and say, do you have pain anywhere in your body? And if they say no to that, maybe you want to ask about, have you got any pain in your flanks or any pain when you're urinating? And that might elicit a yes. But that's how you take a pain history. And then from there, you want to ask about any symptoms that arise from urination. So we call these the lower urinary tract symptoms because they're associated with your bladder and the act of urination. So we're going to have a look at these now. And when it comes to these lower urinary tract symptoms, the first one you'll normally talk about is volume and frequency. And that's to do with the amount of urine they're producing and the number of visits they're having to the toilet to anticipate producing urine. So with amount, you can have anuria, which is pretty much producing no urine or very, very low amounts of urine. And then you also have oliguria, which is producing less urine than normal. And then you have normal, you have polyuria producing a lot of urine. And then you have nocturia, which is where they're waking up at night, being woken up at night to go into the toilet to urinate. Again, these actually have specific definitions in terms of volumes, but I think when it comes to your history, all you have to really know is categorizing them as going more frequently or going less frequently, and then correlating that to particular pathologies that can occur. So yeah, also ask about number of visits because that can be very different. So for example, if a person is having some sort of a bladder infection, that might be irritating their bladder and causing them to go to the toilet a lot more. But if the bladder is already quite empty from having gotten rid of all their urine, they might not actually be producing any urine despite going to the toilet to urinate. So that's an example of where the number of visits and the amount might not always correlate. So important to ask about both those things. But then you have the rest of your symptoms, which are retention. And in particular over here, you'll learn about this French phrase, pisson d'eau. I'm not sure if I'm saying that right, but that's where even after emptying your bladder, you still feel like you have a little bit left and you want to go again. And so that's called urinary retention, or we often say that in clinical histories as pisson d'eau. And then you also have urgency. Urgency is where you have like an unstoppable urge to go to the toilet whenever you to urinate whenever that arises, and that can be associated with some sort of like irritative condition. So that can again be a bladder infection. And then you also incontinence, and that's where you're unable to control and hold in your urine. So three important terms you have to learn and know what they mean separately as well, because you're going to ask about each of them when it comes to your urinary history. You also have questions about stream. Now, stream is asking about the stream of urine they're producing. You want to ask, is it a bit hard starting that stream of urine? So is there any hesitancy? Is that stream that they're producing poorer or weaker than usual? So is it not going as far, or yeah, is it weaker in that sense? So being shorter than usual. And then you have terminal dribbling. So at the end of that stream, when they've finished urinating, is there still a little bit of urine that trickles out? And that's called terminal dribbling. And if that's a bit hard to remember all those symptoms, you can think of them broadly as being divided into irritative symptoms and obstructive symptoms. So irritative is where there's some sort of irritation in your bladder that's making you want to go more and produce more urine, or get rid of more urine. And that's called, those are basically your frequency symptoms, your increased frequency because of the irritation. you're going to have urgency because that irritated bladder is going to want to get rid of the urine. And then you also have nocturia because you're going so often, it's even also impeding into your nighttime sleeping schedule as well. You also have obstructive symptoms where the flow of urine can be obstructed. For example, in benign prostatic hyperplasia, which you'll learn about, you can have the prostate um, sort of physically enlarging and obstructing the urethra. And as a result, you get symptoms like hesitancy and straining, where you're trying to really push out that urine, but you're not able to. Incomplete emptying. So even though you've gone to the toilet and urinated, you still are unable to completely empty your bladder because of that obstruction. Intermittency, and a weak stream. You also have other things to consider here, like with the appearance of the urine and the smell. So in terms of appearance, one really important thing you want to ask about is blood. So that's called hematuria, where you have blood in your urine. But that's going to lead you to think about things like trauma that might have arisen from maybe inserting a catheter, could be from inflammation or disease with an infection. So it could be a lot of things. It could also just be that they've had certain foods like beetroot juice that has a particular dyes in them that make your urine look like it's got blood in it, but it's actually because they just drank a lot of purple juice. And you also have other things when it comes to appearance and smell. So again, if you remember back to our GI systems review, we talked about how with jaundice, particular types of jaundice, so I think it's post-hepatic jaundice, you can expect them to have darker urine. And if they have brown urine, that could point towards something like kidney failure, whereas cloudy and smelly urine more so points towards an infective cause, which is like all that pus coming out into the urine. If they have frothy urine, that can indicate that there's a lot of protein inside the urine, so proteinuria, and that might indicate the kidneys are damaged and they're leaking out protein. So we call that nephrotic syndrome, and you'll learn more about that as well. In terms of other things you can ask about, there's infection symptoms. So in particular, you really want to ask about fever because a fever more so leads you to believe it's an upper urinary tract infection rather than a lower urinary tract one. And then you also might do some screening for CKD or chronic kidney disease. There's a lot of things you can screen for, but I focused on a couple important ones here. So with fluid overload, because your kidneys can't really filter out a lot of water when they're impaired in their function, you might expect a bit of ankle swelling, shortness of breath. You probably expect a bit of oliguria, but in some cases, when the kidneys are damaged, they can also produce a lot more urine. So you might get poly and nocturia as well. Then because of your kidneys being unable to get rid of the uric acid and it building up inside your body, you can end up with uremia, and you might feel tired, you might feel a bit weak, have some hiccups, and feel a bit itchy as well because of that uremia. So that's another thing you can screen for in CKD. So that's pretty much all of the urinary history done. As you can see, it's quite short. So it's really important that you have a look through those questions and see if you can understand and get your head around them. In future videos, we're going to be looking at examination of the urinary system or the renal system, and then correlating all these things with particular pathologies. But in terms of your OSCEs, it's important that you know these system review questions very well. And again, if you want a mnemonic, there's one that's given to you. But I think one way you can easily remember this is that, first of all, with any history, you're going to ask about pain, regardless of what history it is. But then you can move on to asking those obstructive questions and then those irritative questions and separating it that way. And then finally ending it and capping it with discussion about infective symptoms and then a quick CKD screen as well. So again, that was a very short and quick video about the urinary history. If you have any questions, concerns, feedback, let us know in the comments or message us individually and we'll be sure to get back to you. But until then, see you in the next one.